To our live webinar. My name is Jesse Gutnick. I'm a weight loss surgeon. We have an excellent panel here today to talk about both medical and surgical options. Karen Schulz, Natalie Larson, Bernadette Brown, and myself. Our agenda for the seminar is first off to hear Bernadette's story from a patient's perspective, her weight loss journey. Natalie's going to talk about the medical treatments for obesity. I'm going to talk about surgical treatments. And then Karen's going to talk about next steps for both the medical and surgical programs. We'll also have a Q&A. Please feel free to send in questions. We actually got a lot of questions pre-submitted, which we're going to start off with. And hopefully, if we have time, we can get to some of the additional questions that that you guys are able to send in. And with that, I'm going to turn things over to Bernadette.
I think you're muted, Bernadette.
Hey guys.
There you go.
Can you hear me? So I just want to share a little bit of my story. I'm gonna start by advancing to that slide. So I was a preemie. I started off 4 pounds, 14 ounces. That was the last time in my life that I was the smallest girl in the room. By the time I was 12, I was about 5'5" and 180 pounds, bigger than the other girls in the room. By 14, I was up to 218, where I kind of hovered for a long time. Fast forward to my early 20s, had 2 kids, married, but then my daughter passed away. My husband and I got divorced, and I ballooned to 304. I ate, I slept, I cried. That was my life. Go on to the next one. Tried everything I would see come on TV, I'd try it. Keto, Atkins, Slim Fast, Weight Watchers, anything I saw on TV. I mean, anything. The fad diets online, personal trainers. I even did martial arts for a while, boot camp, Zumba. Never had a problem losing weight. Always had a problem keeping it off. Wanna go on to the next. So I am a daddy's girl, and enough was enough. Watching my dad, who was super strong, active guy, all his life, construction worker. He was diagnosed with heart failure in 2010. It was end stage by 2011. Same time I was in nursing school. He's the one with the heart failure, and my joints are hurting. I'm going to the ER for chest pain, had hypertension, was pre-diabetic, in the middle of nursing school and teaching other people about, how to prevent those things. And I was talking to my dad about it and just kind of complaining about it, and, as nicely as he could say it. He's like, I don't want to hurt your feelings, but you need to lose some weight. My dad ended up passing away in 2012. Back to my pattern, eating, sleeping. I did what I had to do. I finished nursing school, ate, slept some more, studied, passed my NCLEX. I was all done, but here I was, this nurse at 300 some odd pounds. But I had to do something about it, because I would get these looks from my patients like, how are you telling me what to do when clearly you're not listening to yourself? So I promised myself that I would make my dad proud and fix myself, or help myself. Can we go to the next? So I started with the bariatric program. I actually went through the bariatric program here at Cleveland Clinic. got accepted into my program, and my actual surgery was done in December of 2014, right around Christmas time. My family actually got me different flavors of Atkins shakes to have while my family had dinner because I was determined to do it. I got my surgery and I took off from there. I hired a personal trainer. I was not going to do this for nothing. I mean, instead of the eating, working out was my everything. I love lifting and yoga and all those things. I lost a bunch of weight pretty quickly. And I've had some ups and downs. I lost weight. I've gained some over the years. I'm back down to around 190 now. But my biggest regret is not reaching out and getting some help sooner. Yeah, so I'll move on to the next one. And those are just some of the pictures when I was with my personal trainer. On the right-hand side, there is when I was at one of my in-between weights, and on the left-hand side, there is when I was at my smallest. So yeah, that's my story. That's about it.
Well, thank you for sharing, Bernadette, and I'm sure you're going to have a lot of questions from the people that are on our call today. It's a very emotional story. And with that, I'm going to turn things over to Natalie to talk about some of the medical treatments for obesity that we offer.
Thank you, Dr. Gutnick. So my name is Natalie Larson. I am a nurse practitioner here at the Bariatric and Metabolic Institute. Today I will be discussing medication therapy interventions for obesity. So at the BMI, we provide many different medical weight management options for individuals living with obesity. So at your appointment, we will provide thorough evaluations and diagnostic testing that is performed by obesity-trained medical providers. And we will come up with an individualized treatment plan for you in a multidisciplinary obesity care setting. We work closely with the bariatric surgery team, registered dietitians, our clinical psychologists, and exercise physiologists, along with many other specialties to meet your specific needs. And we also use a combination therapy approach for obesity management. Next slide, please. So approach to treating obesity, there are many different treatment options, as you can see, and pharmacotherapy is just one of those options. Other treatment options include bariatric surgery and lifestyle changes through diet and exercise, along with other behavior modifications. Next slide, please. So as you can see here on this slide, we do utilize a wide variety of medications for obesity management. We also utilize many of these medications in treatment for other pre-existing conditions that individuals may have, and try to find a medication option that will serve a dual purpose or benefit. So here on the left-hand side of the screen, you can see the first generation anti-obesity medications, and then we get into our second generation and third generation. We also have a new medication that has come out on the market that treats different genetic forms and variations of obesity as well. So we also use a lot of medications that are FDA approved but off-label in regards for weight loss, but they also treat other pre-existing conditions that individuals may have related to obesity or their weight. So these medications here are for diabetes. As you can see, many of them are the injectable medications that are newer to the market. And then we also use some different medications for seizures and migraines that help with weight loss and also depression. Next slide, please. So some of you may be wondering how anti-obesity medications work. So prescribed weight loss medications essentially work by trying to lower the weight set point, which will be discussed. The medications may also help with reduction in hunger, increasing satisfaction with less food, reducing binging and cravings, and also helping to reduce preoccupation with food, known as like the food noise. And medications also work to help to increase metabolism. Weight loss, we always like to make sure everyone is aware that weight loss varies from person to person. So different medications may work differently for other individuals. So it's really truly a trial and error process until one or a combination of medications may work for you. Next slide, please. So this is just a little graph that kind of explains where obesity treatments work specifically. So many of the medications that we use act on different hormones and pathways in the stomach. They also communicate with neurotransmitters in the brain. So specifically in the hypothalamus region where the reward center is located. And so this is where a lot of food noise and thoughts surrounding food occur. And so some of these medications may help with satiety or feeling satiated with food that you eat. Next slide, please. This is just a graph that explains the effectiveness of anti-obesity medication. So as you can see, individuals are losing a significant amount of weight, more so with some of these newer injectable medications that have come on the market, specifically around 2020, after 2021. So there's between about a 12 to 15% total body weight loss average for individuals that are on semaglutide, also known as Wegovy, which is FDA approved for weight loss, or Ozempic, which is FDA approved for type 2 diabetes. And then we also have tirzepatide, which is this this blue one here that's the largest in the bar graph that shows around a 20% total body weight loss reduction in individuals who are on tirzepatide. So that would be Zepbound, that is FDA approved for weight loss, and Mounjaro, that is FDA approved for type 2 diabetes. Next slide, please. So as many of us know, obesity is associated with many different health complications, as you can see in this photo, such as heart disease, diabetes, non-alcoholic fatty liver disease, migraines, headache, acid reflux, osteoarthritis, sleep apnea, asthma, infertility, and different psychosocial factors such as depression and alterations in body image, just to name a few of them. So this photo just represents some of the few major weight-related diseases that are associated with obesity. The higher the body mass index, the higher your health risk is for the development of these obesity-related complications, along with a higher risk for cardiovascular disease. Next slide, please. This slide shows the different medications that target GLP-1 hormones in our stomachs and in our brains as well. So evidence is revealed with the injectable use of medications, specifically the GLP-1 and the GIP. There has been already established evidence that these medications help with pre-existing conditions that individuals may suffer with, such as established heart disease, fatty liver disease, kidney disease, and also sleep apnea. Next slide, please. And as you can see, there is more of a weight loss benefit when we use, we have to click a couple of times here to get the whole, thank you. There's definitely more of a weight loss benefit when we utilize a combination approach, which would be utilizing healthy lifestyle interventions, pharmacotherapy interventions with the medications we just discussed, and also weight loss surgery interventions. And so that is our main goal here in the BMI, is kind of having a combination approach. So medications are used frequently in individuals who also are undergoing bariatric surgery. Next slide, please. So some of you may be wondering if you qualify for some of these medications. There are many different clinical indications that may advise that a patient is starting a medication is necessary for treating overweight or obesity. But as of now, the current guidelines would be individuals with a body mass index of greater than 27 with coexisting obesity-related comorbidities, or a BMI 30 or greater. We also utilize the medications in bariatric and metabolic surgical patients. We use the medications for preoperative management, which is typically 0 to 6 months, preoperative combination therapies with anti-obesity medications for BMI 60 or greater, and postoperative medical management at 3 months, 6 months, 9 months, and 12 months, also annually after bariatric and metabolic surgery. And then we also use these combination approaches for patients who have gone bariatric surgery maybe in the past, who are interested in maintaining their weight, or if they have any sort of weight reoccurrence after surgery. We also utilize anti-obesity medications preoperatively in individuals who may be preparing for an operation, such as an organ transplant, a joint replacement, or a hernia repair surgery. Next slide, please. Overall, the main goal of combination therapy is to create a personalized obesity treatment plan specific to your needs. So through healthy lifestyle, medication, and again, bariatric surgery, they all work together in combination to change appetite regulation and also alter metabolic signaling, which then leads to improvement in obesity and the obesity-related health conditions that we discussed today. And this is the main overall goal of combination therapy approaches. And so this just demonstrates why it is imperative to work with all of our multidisciplinary specialties in our group here at the BMI throughout your treatment process. Thank you.
Thank you, Natalie, so much for that introduction to the medical treatment for obesity. I'm going to briefly touch on weight loss surgery. This is a very high-level overview, but I think it does build on a lot of what Natalie already talked about for everyone. So as Natalie said, the idea behind all the treatment methods for obesity, whether it's medications or surgery, is to reset our set point. And our body work, when we talk about the set point, it's an analogy or a metaphor for our hormonal balance in our body, that it determines where our weight is. And it works very much like a thermostat in your house, where you set a temperature and it tries to maintain that temperature. And the way ours works is kind of like the heating system, where if it drops down below a certain weight, the hormone changes so that we regain weight to that level, sort of like your heating system. If it gets cold in your house, it turns the heat on. But it doesn't necessarily regulate you as strongly as weight rises. So your weight may rise, but it doesn't like to drop. And that's the set point. When you diet, when you purposely eat less food, your body changes how your body processes the food by changing your hormonal balance, and it fights the weight loss. The weight loss medications and the weight loss operations, in a more powerful way, reprogram how your body manages that food and resets that weight thermostat, as it were. The most common operations that we perform are the sleeve gastrectomy and the gastric bypass. We also offer duodenal switch, SADI surgery, and revisional surgery, which I'm going to talk about all of them to some degree or another. I want to show you guys a tool which you may want to use about yourself. It's free to use, and it's called the MBASQIP Bariatric Surgical Risk and Benefit Calculator. And in this, you're able to put in your own personal information and get a sense of what the risks are for surgery for you and what the benefits are, both in terms of weight loss and in terms of heart or other health issues to improve. So I put some information in a sort of a hypothetical patient here whose BMI is 40. It's a 40-year-old woman, and the person does have diabetes, and they have high blood pressure and sleep apnea. And then from this, they can use this from prior information to look at how much weight loss you could expect with the different operations. And this is over a year. So at the bottom of this graph, it's the day of surgery, and then out here is at 12 months. The up and down graph is the percent weight loss change. And so the GLP medications, which are the new injectable ones that Natalie talked about, that are the most powerful medications we have, most of them are somewhere in the 15 to 20% weight loss frame. Sleeve gastrectomy tends to be about 20 to 25%, gastric bypass around 30%, and duodenal switch in the mid to high 30s in terms of the percent weight loss. And these are similar in terms of the overall percent total weight losses, depending on where you start. But this calculator is often best used when you consult with your surgeon, but it can give some sense of both the likely weight loss you can expect with the different procedures and the chances of your other health issues improving. So that can help in terms of making a decision if you're on the fence or interested in a different operation. To give you a sense of the most common ones that are done, 90% of them are either gastric bypass or sleeve gastrectomy. Gastric bypass, on the left-hand side of your screen, we bypass most of your stomach and then directly connect this new small stomach to the small intestine. The sleeve gastrectomy, we remove part of your stomach that expands when you eat a meal. And it ends up looking like, you can imagine it's similar to a sleeve where there's a seam on one side, just like on a long sleeve. The main concern people have about surgery is the safety. And I think when we consider safety, I think the best way to think about it is both the safety of surgery itself, immediate and long term, and then also compared to not doing surgery or what we would call usual care. And there's really two components. One is the risk of surgery, which is small, and the health benefits over time, which are quite large. In the 2000s, there was a revolution in bariatric surgery with two things. One was the creation of specialized training programs to train bariatric surgeons at an extremely high level. And the second one was the advent of laparoscopic surgery. And the combination of these two things completely changed the safety profile of surgery. From, as you can see, in 2002, there was a risk of 4 in 1,000 patients, risk for death in 4 in 1,000 patients. And this dropped well below, by the end of the decade, to half of a person per 1,000 risk of death. And it's continued to drop since then. And as of now, it's dropped down to about approximately 0.8% risk of mortality, so extremely low. And the risk of weight loss surgery has, in terms of both major complications and minor ones, believe it or not, is lower than gallbladder surgery, hysterectomies, or joint replacements, commonly performed operations. On the flip side, over the long term, you get a significantly improved life quality and length of life by treating the health issues that come, or even more importantly, by preventing them from happening. Most commonly, sleep apnea, diabetes, improving the safety of bearing children, improving the quality of life with joint pain so people can be more active. The biggest area of research right now is probably the decreased risk of certain cancers that are related to obesity, and treating fatty liver and many other health issues relating to obesity. And with that, I'm going to turn things over to Karen to talk about some of the practical aspects of next steps.
Hello, everybody. My name is Karen Schulz, and I'm an advanced practice nurse seeing patients at the Bariatric Metabolic Institute. I'm also the enterprise administrator. So I'm going to talk a little bit about next steps and what our program is like. First, I want to say that I really appreciate all of you for choosing the Cleveland Clinic for your health care and taking the time today to learn how we treat patients with obesity in our program. So the weight loss surgery programs that we're talking about today reside inside the Digestive Disease and Surgery Institute, which is listed as the #1 in Ohio. And we also provide care at several of our area hospitals who are highly rated as well. So you're in a good place. Next slide, please. We have a very large, comprehensive, multidisciplinary program, probably one of the largest in the country. Just to give you an idea, we have 12 obesity medicine providers, 5 physicians, 7 nurse practitioners. We have 9 dietitians, 7 psychologists, 13 surgeons, and lots of convenient locations to hopefully serve you and your community, including the fact that we also do virtual visits. So we know life is busy, and if you would like to have these visits in your home, as long as you're within the state of Ohio, we can do that as well. We like to see you, though, as often as you can come visit us. Next slide, please. So for the medical weight loss program, no registration is required. But honestly, you probably should check your insurance, because although most insurances will cover obesity treatment, especially if you have medical conditions associated with them, it's just a good check before you schedule that appointment. The other thing is that some of our patients like to check to see if they have coverage for some of the obesity medicine medications, but we'll also take care of that for you if and when you come to see us for an appointment. So the main thing, you'll have an obesity medicine provider. You may or may not have a registered dietitian if you need that assistance in the program. And we have lots of consultants to help you treat obesity-related health problems if that is something that is an issue for you. So to make an appointment, there's a phone number here, 216-445-3136. We'll also show you this number at the end of the presentation, and that is the best way to schedule your first consultation. Next slide. So navigating to your weight loss surgery goals, if you decide that you would like weight loss surgery, you will need to register. And the reason for that is we want to check insurance requirements before you enter the program to make sure you have coverage. Okay, so if you're not sure on medicine or surgery, you can go ahead in the medicine program, and then you can switch to surgery later on, or back and forth. We all work together as one team. And then each person, once you enter the surgery program, has a patient navigator. And they help to organize your information. They make sure you have insurance coverage, and they will submit your case to insurance before surgery to make sure that you don't have any financial concerns before that operation. Next slide, please. The surgery team will consist of 4 main providers, and their job is to prepare you over a journey of about 3 to 7 months for your operation. Each visit, each provider is going to address a separate area of preparation. So of course, the dietitian is going to teach you how to eat to prepare you for the eating after surgery. Our obesity medicine physician is going to make sure you are absolutely as healthy as possible before undergoing the operation. Our bariatric psychology team is going to address the emotional and psychological preparation for surgery. If you currently have a mental health care provider, they will work with them to make sure that you're in the best shape possible. And then, of course, your bariatric surgeon, you're going to meet with them, and at that time, you'll decide which operation is the best for you. I think the thing to remember is by the time you get to surgery, you will feel completely prepared and ready to go. We also have consultants. So if you have any obesity-related health conditions, we have those individuals here at the clinic to help, or we can work with whatever providers you currently have on your healthcare team. Next slide. So what are the next steps for the bariatric surgery program? Because registration is required, we ask you to go to Cleveland Clinic Bariatric Surgery. You can just Google it, or clevelandclinicweightloss.com. And there's a seminar. It's different from this one, has a little bit more specific information. It's recommended, not required. And there's a short registration questionnaire. And with the information we see on your registration, we'll check your insurance benefits the next day. If you have coverage, we'll contact you to see if you'd like to schedule an appointment. And if you don't have coverage, either way, we'll contact you via email or my chart to let you know what those next steps might be. Okay, that is it. Thanks, everyone.
Come back on with their video and audio. We'll do our Q&A session. So I'm going to start off with some of the pre-submitted questions and direct them out. First, and probably one of the most common questions, Natalie, can you go over what vitamins people might need to take after weight loss surgery or with taking the weight loss medications?
Yes, of course. So the biggest nutrient deficiencies that we see in individuals on medications also after surgery is going to be specifically B vitamins, so vitamin B1, vitamin B12. We see a lot of vitamin D deficiency. We do a full panel prior to surgery and what also when starting medication to kind of see where you're at as a baseline. And then we really supplement any of those vitamins that need required supplementation. And then after surgery, of course, we follow very closely with the vitamins that you take that our registered dietitians will provide you information with on the bariatric supplements.
And the follow-up question this individual had was, are these vitamins covered by insurance?
So typically, the bariatric vitamins are not covered by insurance. A lot of times as providers, depending on the specific insurance that you may have, we do try to prescribe them to where insurances may cover. However, we also have affordable options for the bariatric supplements specifically for after surgery. So there is a bariatric PAL where we have a coupon that allows for a pretty cost-effective price for a year's supply.
Another common question is about excessive skin after significant weight loss. Karen, can you talk about how common this is? Is this something that tends to be bothersome to most people? And if it does happen, what the options are?
Yes, excess skin after surgery is, it's not super common. It depends on how much weight you lose, the elasticity of your skin, how old you are, and also, of course, how much you exercise. So some of that skin kind of shrinks with you as time goes on. But depending also on your personal expectations, there may be a little extra, especially in the abdominal area. So most people will choose to use supportive undergarments. They look great in clothing, really not a significant issue for people in around the 100-pound weight loss, around 100 pounds and less. If you're talking about, someone who's more than 100 pounds, it's possible, depending on all those things I mentioned, that some excess skin may be bothersome. And we do have an amazing team here at the Cleveland Clinic that does some plastic surgery procedures, especially in the abdominal area. So again, it depends on also personal expectations. If you want to have a perfectly flat stomach, probably not going to happen. If you want to have, plastic surgery options, great program. They mostly are not covered by insurance, although I know that in some instances, especially in the abdominal area, our plastic surgeons are able to get some coverage. So very individual, not normally required, but sometimes that option is chosen by our patients.
I'm going to take the next one. This patient asked, does any hardware remain in the body after surgery? And the answer is no. So there were some prior bariatric operations that are no longer performed, called the vertical banded gastroplasty, the VB or the VBG, or the lap band, where there was material implanted. The current operations, that would be the sleeve gastrectomy, gastric bypass, and the duodenal switch, do not implant anything. Surgical stapling is performed, and so you have some tiny little titanium staples that are smaller than a millimeter that remain in place that don't affect you. They're MRI compatible, and they're not considered an implant. The same person had a follow-up question, which is, do stomachs stretch back to a larger size after surgery? And if so, what problems does that cause? The answer is, for the most part, no. So if you construct them properly, they should not significantly enlarge. When we do a sleeve gastrectomy or a gastric bypass or the duodenal switch, we exclude either block off or remove the part of your stomach called the fundus. That's the stretchiest part of your stomach. And if you leave fundus in, then it may stretch. But if that is either excluded or removed, then it should not significantly stretch over time. Most people do have an adaptation process where they're able to tolerate a larger amount of food over time because you kind of get used to the smaller stomach from a brain perspective, but the stomach itself does not typically stretch. And Natalie, I'm going to send the next question over to you. Can phentermine be taken long term?
Yes. So phentermine is now FDA approved for long-term treatment for obesity management. So we do prescribe phentermine long-term. And I also wanted to elaborate.
And that's a new change.
Sorry?
And that's a relatively recent change.
Yes.
Some of the changes around the rules for phentermine prescribing.
Yes. And one more thing I wanted to mention on the vitamin and mineral supplementation. I don't know for that question. I don't know if I added in iron because we see iron deficiencies quite frequently, and so we do supplement iron, and we also supplement calcium and a lot of different micronutrient vitamins as well, like zinc and copper, which are not as common, but more specifically for the Roux-en-Y gastric bypass. But I thought I would add that in there.
There were several questions, both on the pre-submitted ones and on the chat, about insurance coverage. One thing I want to clarify is someone did mention specifically that they have Aetna and it does not cover. Usually Aetna does, but you may have a specific exclusion to your Aetna. Either way, to find out what your coverage is, if you fill out the questionnaire for the bariatric surgery, we'll double check what your coverage is and get that information to you. But Karen, for the people that don't have coverage for medications, especially in particular the GLP-1, the injectable medications, are there any options?
Yeah, Natalie talked about a lot of other medications that can be used instead of the GLP-1s that are either covered by insurance or low cost, such as the phentermine. For the GLP medications, though, there are a few insurance companies that cover them. Patients suffering with diabetes, we can get coverage sometimes for them. And then intermittently, the companies have coupons that we'll tell you about. But those are the more expensive medications, especially right now. I don't know if Natalie has anything to add, but if you don't have coverage for the injectable medications, we will try to work with something that is more affordable.
One question I want to answer off the chat: does this meeting count for your nutrition visit? No, this is not a medical visit at all in any form. This is an educational session. If you are with our weight loss, medical, or our surgical side of things, your nutrition visit will be a meeting with a registered dietitian, which will be a medical visit with the registered dietitian. Natalie, can you talk a little bit about how treating obesity helps treat fatty liver? A patient was wondering about treating their fatty liver.
Yes. So essentially, we see a lot of the times as individuals lose weight, as we know, many of us may know that the liver toxins a lot. It eliminates all of the toxins that kind of go into our body, and how that's associated with obesity is sometimes there's fat buildup in the liver. And so as we see that individuals lose weight, their liver enzymes tend to come down, and we see that the liver is not filtering as much fat buildup, and so it does help to treat fatty liver disease.
Perfect. I'm going to answer the next one. Some more surgical questions. What kind of side effect can we expect from weight loss surgery? And is there an upper age limit for weight loss surgery? In terms of side effects, it depends on the operation chosen. And really, your consultation visit, what it's highly directed towards is finding out what current symptoms you have and how the operations might improve those or worsen them, depending on what they are. And a lot of choosing the right operation for an individual person is working around the symptoms people already have to minimize what the side effects or the symptoms are afterwards. And so that's really kind of a more complex thing to find out where you are and then how the operations interact with that. That's best done on an individual basis. There's no upper age limit for weight loss surgery. There's no hard and fast number because as everyone is aware that age is only a number. There can be a 40-year-old who's very medically unwell that may not be a candidate, and you could have an extremely robust person at 70 who is much healthier than that 40-year-old who would be a much better candidate. That being said, it's highly unusual for someone to not be well enough to undergo weight loss surgery, but you may need to get prepared preoperatively by tuning up a heart problem, for example, or a lung problem, for example. I think that's probably about, I don't know what it is for other surgeons. For me, it's about once a year. I meet with somebody, and after talking to them, we decide that they're just too medically unwell to go undergo surgery. So that would be the very, very small minority that would not be able to tolerate it from an age or a other health issue perspective. Karen, there's some questions about what's the level of support after surgery, or what kind of support do we offer after surgery? If you could go through that.
Yeah, there's routine visits after surgery, starting off more frequently in the beginning and then going out for life. In the beginning, our patients will come back really as often as they need, but usually it's at about 1 week to 10 days, then 1 month. That's either virtual or in person. Then we have a 3-month visit, a 6-month visit, and then unless needed, the next visit is at 12 months, and then 18 months, and then once a year. In addition to those scheduled visits, there are support groups, which are virtual, and they're held twice a month. So the first Wednesday and the third Monday of the month from 5:30 to 6:30. Those are held by our team, our dietitians, our psychologists, various staff members, surgeons, talking about various topics. And those are optional, but certainly a great source for support. And not only informational from our providers, but also our patients supporting one another. And in addition to the visits, also we check some blood work at intervals more frequently the first year, and then once a year after that. Some patients choose to follow up for that yearly visit with our primary care providers, but we do recommend that it be done in the bariatric surgery program, if at all possible, because we kind of know the questions to ask, and the labs to order, and things of that nature.
And Natalie, how often do you see patients when you're treating them medically?
So it depends on the patient and their specific needs, but typically once I see a patient for an evaluation, we start medication therapy. I typically like to see the individual back within 2 to 3 months. Typically, it's about 3 months. And then for phentermine refills, for example, they have to be seen with the state of Ohio laws about every 3 months. But we do virtual appointments as well, so not every single appointment has to be in person. And then once individuals are on a maintenance dose of medication, then we can kind of extend that length of time a little bit more, so it's not as frequent.
That's a question for Bernadette. Bernadette, you had gastric bypass surgery. How did you personally pick that particular operation?
When I discussed with my surgeon the sleeve versus the bypass, well, one, I had a bit of a hernia, and the gastric bypass also helps with that when you have reflux and things like that. So for the amount of weight that I needed to lose and the fact that I had a comorbidity that it could also treat, it was the best option for me.
Gotcha. That actually lines up with a question that someone had. They said, I've been recommended weight loss surgery along with repairing a large hiatal hernia. Any additional info would be helpful. And exactly that's what I was going to exactly answer this person is sometimes that's not infrequent to get a hernia of some type. So at your belly button, groin, or around the hiatus, which is in your diaphragm. And the reason that we will sometimes combine hiatal hernia surgery with especially gastric bypass, but some type of weight loss surgery, is it number one, you have to fix the hiatal hernia to be able to do the weight loss surgery the proper way, as if it's more than very small. And secondly, losing the weight helps prevent that from coming back because it takes the stress off of the repair by if there's less weight essentially pushing on it, there's less stress on that repair. Now, Karen, could you talk about there's a person who's concerned about hair loss after surgery. How common is that? And what do we do to prevent that from happening or minimize that?
Sure. Hair loss is frequent during the rapid weight losing phase of our program. It doesn't happen in everyone, but it's normally related to protein. So we do a lot of counseling, nutritional counseling pre-surgery to tell each patient exactly how much protein that they need to get in to prevent hair loss or hair thinning. And when they say hair loss, it's not like chemotherapy where all your hair falls out. It's a thinning.
You don't look like me, in other words.
I wasn't going to say that. Okay. No, it's a hair thinning that happens. And generally, by the time 3 months is sort of the optimal time period, because that's when 0 to 3 months you lose a lot of weight very rapidly. As your weight loss slows down, and it needs to slow down, the hair thinning will also slow down. So protein, some people will take biotin, so that has been associated in some of the studies to prevent hair loss. And some people don't get any hair loss. So it varies across the board. We think, though, that protein has a lot to do with it. We also know that people that lose weight rapidly will sometimes have hair loss. So that part is just sort of expected for most people. So we don't know why everyone doesn't get hair loss. They don't.
I'll take the next question. The question says, are there any bariatric surgeries that are bloodless? I'm going to make an assumption from that question because that's a typical question from someone who, for religious purposes, is unable to accept transfused blood. There's no operations of any type. There's no surgery that is bloodless because anytime you divide tissue, there will be some blood loss. So there's no such thing as bloodless surgery. That being said, bariatric surgery is very, very low amounts of blood loss. So a typical amount would be somewhere between 5 to 15 milliliters, which is quite a small amount. We do occasionally transfuse a patient. It's extremely rare. Like it's the kind of thing where what happens once or twice per year out of many, many hundreds and up to 1,000 patients. It'll happen several times per year. So a long story short, there's no operation that's bloodless. As operations go, it has extremely low blood loss, and it would be very low compared to, say, for example, a hysterectomy or like a bone type surgery, which tend to have more blood loss. Earlier, Karen, you said that typically people are seen for 3 to 6 months before, or 3 to 7 months before surgery. What defines that time frame? Why does it take time before surgery?
The time frame oftentimes is dictated by insurance requirements. So the 4 main providers can normally be seen within a month or two, but a few of our insurance companies require that you stay with us for 6 months, or some 4 months, 6 months. We have a couple that say 12 months to work with our nutrition team once a month, 30 days apart, sometimes consecutive. Those are the types of things that we'll learn for you when we do your insurance check, not only if you have coverage, but also if you have any of those special requirements. Also, there could be some other reasons. Each of the team members is going to assess your health risk. Some of our patients have undiagnosed sleep apnea, so they'll need to take a little break and have their sleep apnea treated. Some patients will discover maybe another issue. Some patients maybe need to work with our psychologist for a little bit longer. Much of that can be done here at the Cleveland Clinic. So although the average time period is 3 to 6 months, could be shorter, could be longer, depending on a variety of factors, individual and also insurance related.
All right, I'm going to ask one more question. I don't know if we answered every single specific one, but I tried to make sure to answer ones that would kind of cover some duplicative ones. But the one final question to Natalie. This patient gained weight due to steroids, and do these treatments help people lose the steroid weight that they've gained?
Yes, absolutely. So very common that we see weight gain with chronic steroid use, specifically like prednisone or from other health complications where steroids are required. And so, yes, we do treat weight loss from that.
Yeah, and the same is true for surgery. One of the things that the obesity, not just for steroids, but that obesity medicine providers like Natalie do when they first consult with patients is do a review of the medications to see if there's any other ones. Steroids are usually the worst ones for weight gain, but any other medications that can be contributing to weight gain, and then consulting with the prescribing provider for that medication. There may be an alternate medication that has less association with weight loss that may be equally effective for the purpose it's being prescribed for. From a surgical perspective, we try to get people prior to surgery certainly before surgery off of steroids, and hopefully transition to another type of medication that's less what's called obesity-genic or weight gaining, so that you're able to have the best benefit from either weight loss surgery, weight loss medicines over the long term, if there's another medicine that can help you as much. And with that, I really want to thank the panel for their time today. Thank you so much for joining. And of course, for the people who joined for the seminar, thank you for joining and taking your time to learn more about. I've got the next steps up on the screen if you want to take a look. And we hope to see you one-on-one to try to help you towards your weight loss goals.